who's from Jerez in Spain. He's a critical care intensivist. He's a physiologist who's mainly focused on the arterial system and heart-lung interactions, and he studied the dynamic arterial elastance. And he's now going to talk to us about differentiating the cause of hypotension.
Thank you very much. Thank you for Edward's Lifesciences for the invitation to this meeting. The role my role here is trying to explain the physiological basis of arterial hypotension. I will try to explain what are the determinants of the arterial pressure, and I would like to also try to explain what are the reasons why the patient is hypotensive. I will try to use very simple terms. I will try to use the physiological language to explain our problems. So this is my disclosure of interests. So I would like to start talking about what is the arterial pressure. Because at the end, when we are at the bedside looking to the patient, if we look to the monitor and we see the numbers of the arterial pressure, and we try to ask to the doctor, is the patient unstable or stable? The doctor is going to look to the arterial pressure. And very often, the doctor is going to define a patient as unstable because the patient is hypotensive. But if you ask to that doctor, what are the determinants of the arterial pressure of that patient, that could be a problem, because I would like to ask you, what are the determinants of the diastolic arterial pressure? What are the determinants of the systolic arterial pressure? We are using those numbers, we are looking those numbers for defining a patient, an unstable patient, or even a patient in shock, and we usually forget what are the determinants of the arterial pressure. So I would like to start talking about what are the determinants of the arterial pressure. We have to remember that the arterial pressure is a product, is the result of the complex interaction between the flow generated by the heart and the arterial system. And we have to remember that the cardiac output is changing every single minute, in every patient, from patient to other patient, because the cardiac outputs try to meet the metabolic demands of the patients. And the arterial system tries to regulate, to compensate all these cardiac output changes in order to keep the perfusion pressure constant in the organs. So when we are looking to the numbers at the bedside screen, we have to remember that those numbers are the product of the combination of the interaction between the heart and the arterial system. So arterial pressure is the variable determined by the heart and the arterial system. And it's easy to understand that when we look at this graph. If we remember the ventricular arterial coupling definition, we will see that the pressure is the result of these forces, these contractilities, the effect of the heart, and the effect of the arterial system. So when we see a change in the arterial pressure, when we see a decrease, for example, in the arterial pressure at the bedside screen, we have to remember, we have to keep in mind that this change could be due to a change in blood flow, for example, during hypovolemia, bleeding, even heart failure, pulmonary embolism, but also could be due to a change in the arterial system, for example, during vasoplasia in septic shock patients, after induction of anesthesia, and more oftenly due to a combination of both factors, a change in blood flow and a change in the arterial system. And if we keep in mind these factors when we are looking to the arterial pressure, if we want to interpret the value of the arterial pressure, if we keep in mind that those factors are affecting to the value of the bedside, we will explain, we can understand why the patient has a lower arterial pressure. So what is the arterial pressure? What is the hypotension? What is the arterial hypotension? So if the arterial system tries to regulate the cardiac output changes, The arterial hypotension is the loss of balance between the flow generated by the heart and the regulation of the arterial system. This disbalance between the heart and the arterial system is the product, is the result, is the cause of the arterial hypotension. This is the classical definition used in the intensive care, published in the intensive care medicine journal, because we need to define a minimal threshold of blood pressure. Below that level, the perfusion pressure to the tissues could be compromised. And the perfusion pressure to the tissues will depend on the systemic arterial pressure. So we have to define a minimal level of arterial pressure. Below that level, we will have hypoperfusion. But it's important to remember, too, that we don't need the arterial hypotension for defining the shock, a patient in shock. It's important because, as I said before, arterial pressure is a regulated variable. It depends on both blood flow and the arterial system. And this is the reason why, when you look to the official or the standard or the classical definition of shock, you will see that the hypotension is usually present during shock, but it's not necessary for the definition of shock. So it's important to keep in mind that the abnormal blood pressure doesn't mean that everything is okay. Obviously, a hypotensive patient means that all this regulation, all this balance between the heart, the flow generated by the heart and the arterial system has lost. For example, we can see this example. We can see here a patient that is, for example, bleeding. So the blood flow decreases. There is some kind of hypoperfusion, but the arterial system tries to keep the arterial pressure in the normal level. But if the blood flow decreases more and more, and the arterial system is unable to regulate this decrease in blood flow, then we will see the hypotension. But at the very first beginning, the arterial pressure will remain stable. So how can we treat arterial hypotension? Well, the first thing that we have to remember are those two factors, the heart and the arterial system. If we want to, if the problem is related to the flow generated by the heart, we will have to increase the flow by the heart. We can do that using fluids or using inotropes. Which one is the best one for the patient is related to a preload dependency of the patient. If the patient is able to increase the cardiac output with fluids, we can use the fluids. But if the patient is not preload dependent, we will have to use the inotropes. But if the problem is related with the arterial system, we have to change the arterial system. We have to use vasopressors. But the most common problem is when we see a problem related with the heart and a problem related with the arterial system. And this is the usual problem at the bedside. I would like to show you this example, this study. This is a multicenter study. The physicians were asked, what are the reasons for giving fluids in the ICU? And the main reason for giving fluids is always the hypotension. So when we have a hypotensive patient, our first approach is usually give fluids to the patient. More interestingly is to see that we use the blood pressure for defining the response to fluid administration. So if the patient is unable to increase the blood pressure with fluids, that challenge is not a good response. That response is negative. So the arterial pressure is the most used hemodynamic variable to define a positive response of administration. But let's see this graph. You will see here different papers in which the patients receive a fluid challenge, the cardiac output increases. So you will see the box is related to the number of fluid challenges. You will see in red the positive cardiac output response defined more than 15% respect with the baseline value. And in the black part of the box, you will see the positive pressure response. These patients are able to increase cardiac output, but are able also to increase the blood pressure. You can see that the positive response in cardiac output is often 50%, but even in those patients that can increase the cardiac output, the positive response in blood pressure is also 50%. So when we are giving fluids, even if the patient is able to increase the cardiac output, only 50% of those patients are going to increase the blood pressure. So if our target is to increase the blood pressure, you have to remember this graph, because if you want to increase the cardiac output and you know the patient is preload dependent, half of the patient are not going to increase the blood pressure. Interestingly, even if the patient is able to increase the cardiac output and the arterial pressure, this increase in arterial pressure is a very small change with respect to the baseline value. So we are only increasing and 10% with respect to the baseline value. And you have to remember that giving fluids, you can increase also the CVP, and you can have a negative effect, a negative impact in the perfusion pressure to the tissues if this increase is higher than the mean arterial pressure. So there is a cost that we have to pay when we are giving fluids, chasing an increase in mean arterial pressure. Because when we are thinking in giving fluids in a hypotensive patient, we are trying to repeat these steps. I want to increase the preload, I want to increase the cardiac output, I want to increase the arterial pressure. For the first step, we have to effectively increase the venous return. Even if the patient is able to increase the venous return and cardiac preload, depending if the patient is preload dependent or not, you will see a significant change in cardiac output. So you have to define if the patient is preload dependent or not. But even if the patient is able to increase the cardiac output, not all the patients that increase the cardiac output are going to increase the arterial pressure. So we have to define another thing, and this is the pressure responsiveness. So these patients are able to increase the cardiac output, but we have to know which patients are also able to increase the arterial pressure with fluids. A few years ago, Michael Pinsky proposed this is a simple ratio between the pulse pressure variation and stroke volume variation. I will try to explain this, the definition of this parameter. This parameter is called the dynamic arterial elastance. Elastance is a change in pressure for a given change in volume. We are interested not in the single point in the pressure and the volume pressure relationship. We want to define the slope of this curve. We want to define how the pressure is going to change with changes in flow. So we have to define what is the slope of this volume pressure relationship. Oh, seems to be a problem with the graph. So if we are able to measure the change in pressure at the same time that we are measuring the changes in volume, we can define this ratio called the dynamic arterial elastance. And we can define the slope of this volume pressure relationship. And we can do that actually at the bedside. We can use the effects of heart-lung interaction due to mechanical ventilation in our patients. We already know that the mechanical ventilation induces cyclic changes in stroke volume and pulse pressure. So we can use these variations over time for defining the slope of this volume pressure relationship. We can measure the pulse pressure variation looking to the arterial pressure waveform, and we can measure also the stroke volume variation looking at the same time at the stroke volume during one single respiratory cycle. So we can look to this. This is the airway pressure in green line, and we can see here, this is the value of the pulse pressure. This is not the arterial pressure. This is the value of the pulse pressure during one respiratory cycle, and the stroke volume. So we can define the change, the relative change during one single respiratory cycle for defining the pulse pressure variation and the stroke volume variation, and for defining the slope of the pressure volume relationship. So we can use these changes over time because, let me see here. For example, we can see this example in this is an experimental animal. We can see here, for example, when we change, this is the blood flow measured with a Doppler, and this is the arterial pressure. Here you can see the stroke volume variation in blue and the pulse pressure variation in red. We can see the relationship changing over time due to a change in the arterial tone when we start a norepinephrine infusion. So we can use these changes in the stroke volume, in pulse pressure, for defining the slope of the pressure-volume relationship. Let me show how. So for example, if we have this pulse pressure variation, and this is stroke volume variation, for this change in stroke volume, we are going to have this variation in pressure. This will define a slope of this number. This is the dynamic arterial elastance. This is the relationship between pulse pressure variation over the stroke volume variation of 1.93. For the same change in stroke volume, we will see a lower change in pulse pressure. Even if the patient is for the same degree of preload dependency, we will see a different change in arterial pressure. So if we want to increase the arterial pressure, if we give fluids to this patient, we are going to increase the cardiac output, but most probably the arterial pressure is not going to change. I'm sorry. This was not the original slide I have to use. And we can use, we studied this physiological approach to a hypotensive patient a few years ago, and we found that this parameter, this functional parameter, this dynamic parameter, is able to predict which patients are going to increase not only the cardiac output, but also the arterial pressure. We also demonstrate a few years later that even using different technology, the prediction of this parameter is much better than any other arterial system parameter for predicting the arterial pressure response to fluid administration. So this parameter could help us to define if the patient, if a hypotensive patient is going to increase the arterial pressure and the cardiac output with fluids, or if the patient only giving fluids are not going to increase the arterial pressure. So we have to add to the patient a vasoconstrictor infusion. And the prediction performance of this parameter is much better than any other arterial system parameter, even than the baseline mean arterial pressure. So I would like to show you, this is only an example. It's not an actual protocol. It's only a physiological example, a physiological approach to a hypotensive patient, according to the physiological basis I exposed before. If the patient is able to increase the cardiac output with fluids, if the patient is preload dependent, we can give fluids. But if our target is to increase the arterial pressure because the patient is hypotensive, we can use this dynamic arterial elastance. So if this dynamic arterial elastance is telling to us that the patient is not only able to increase the cardiac output, but also the arterial pressure, give only fluids. But if this dynamic arterial elastance is low, you have to keep in mind that only giving fluid is not enough for increasing arterial pressure. So you have to consider to add also vasoconstrictor infusion. But if the patient is not preload dependent, forget about the fluids. It's not the solution for this patient. So you have to consider vasoconstrictor or inotropes. So this is not the right solution for this patient. So in summary, I would like to tell you, I want to tell you, that the arterial pressure is the result of the interaction between the heart and the arterial system. Please Always consider this sentence when you are looking to those numbers at the bedside. Is not only related to flow, it's also related to the arterial system. That the arterial hypotension is the consequence of loss of balance between the blood flow and the regulation of the arterial system. And the functional assessment of the arterial system, the arterial load, may help us to define the best treatment for a hypotensive patient. Thank you very much.